Continuing the series of general physical examination, that is pickle. Today we will discuss about clubbing. So first we will look at the definition. So what is clubbing? So there will be bulbous enlargement or swelling of the tips, terminal parts of fingers and toes. This is mainly because of the proliferation of the connective tissue underneath nail. So mainly because of soft tissue growth under nail. So this is the definition of clubbing. And how does it start? So how do you examine clubbing? Mainly we have to start by looking at the onychodermal angle, we'll say. So first point to remember in clubbing examination is observe for onychodermal angle. So what we'll do is there will be an angle formation at the junction of nail and this nail fold. So nail, that is onycho, and the nail fold, that is derma, skin. So this angle, as we can see, this will be normally 160 degree. To understand easily, suppose at the nail fold, if the junction of nail is at a perpendicular angle, suppose the nail was straight like this, it would have formed 90 degree. But here in normal situation, the nail is flat, almost in line with the skin fold. So this angle will be around 160 degree. This is called as onychodermal angle, nothing but Lowy bond angle. So normally it will be 160 degree, also called as Lowy bond angle. So this one we have to observe. So for this, what we will do, we will take the patient's hand and keep at the level of our eyes, and we will carefully observe for the angle. If the angle is lost, suppose there is growth of soft tissue, as discussed in the definition. If there is growth of soft tissues, this will get enlarged. So obviously it will lead to a straight line formation. So that is nothing but 180 degree. Or if the tissue grows further, it will even lead to increased angle, more than 180 degree. So this loss of Lowy bond angle, that is, suppose there is 180 degree or more, we consider it as presence of clubbing. So this is the first thing. Then we can do fluctuation test. So what happens is, I will just give a demo here. Suppose if we consider this as patient's finger, so the examiner will first try to rest the patient's finger over both the pulps of the thumb. Then what we'll do, we will support the patient's finger with using both the middle fingers at the level of proximal interphalangeal joint. So we have given the grip. Then what we'll do, at the level of nail fold, that is nail bed, slightly palpate, that is slightly give the pressure like this. Often we will see there will be slight fluctuation even in normal persons. Slight fluctuation can be seen. But if the fluctuation is more obvious, or if it feels like as if the nail is floating over the nail bed, that is considered as significant or positive fluctuation test. So first, rest the patient's finger over the pulp of thumbs, then grip the finger using both the middle fingers at the level of proximal interphalangeal joint, then at nail fold level slightly give pressure and look for the fluctuation. So this is called as fluctuation test. But the thing is, it is subjective variation will be there in this test. So interpersonal variation is very common. So it is not much reliable to do this test. Helpful one is onychodermal angle. But some people will start testing for clubbing by looking at the diamond shaped window formation. You might have seen this. So this gap between the terminals of the thumbs or any other digits, it will be diamond shape. So this is lost if there is enlargement due to soft tissues in the terminals. So this is called a Shamroth sign. So third point is Shamroth's sign related to clubbing. And as the soft tissue grows more, these are all considered as grade 1. That is grade 1 clubbing. As the soft tissue grows further, there will be grade 2 clubbing, in which there will be glossy nails. So because of anterior-posterior diameter increase and even the transverse diameter of the terminals will be increased, it will lead to glossy, shiny nails. So mainly increase in AP and transverse diameter. In grade 3 clubbing, further increase in the soft tissue will give appearance of bulbous enlargement, so which might look as parrot beak or drumstick appearance. Then comes grade 4. Along with these grades, there will be enlargement, painful swelling of the wrist or ankle or some other joints, commonly that is wrist joint. So which is called as hypertrophic pulmonary osteoarthropathy. Grade 4 clubbing is called as hypertrophic pulmonary osteoarthropathy. So osteo means bones and joints related, and hypertrophic, so there will be increase in the tissue, that is subperiosteal bone will grow. So that's why it is called as hypertrophy. Why they have added pulmonary is because commonly this grade 4 clubbing is seen in bronchogenic carcinoma. That's why they have added the word pulmonary. So these are the grading of clubbing. Coming to the conditions causing clubbing. So we have to consider clubbing is considered as a window in clinical practice. So it might be the presentation of many underlying systemic diseases. To list them, in pulmonary or respiratory system, mainly bronchogenic carcinoma, and lung abscess, empyema thoracis, even interstitial lung diseases, and many others. In cardiovascular system, we can remember the causes using ABCDE. So A for atrial myxoma, B for bacterial endocarditis, C for cyanotic congenital heart diseases, D nothing. E is for Eisenmingerization. So these are the cardiovascular causes. Then to name some abdominal GIT causes, we know that Crohn's disease or inflammatory bowel disease, then liver abscess or hepatocellular carcinoma. So these are few conditions to name. Here we are listing out the conditions. Meanwhile, we have to discuss various theories of clubbing. So mainly we can consider theories such as theories of clubbing. First one is genetic theory. So some people will develop clubbing because of some genetic mutations or inheritance, which will be non-pathologic. That is called as genetic theory. Second important theory is called as anoxic theory. Here, whenever there is decreased oxygen supply to the terminal phalanges or terminal tips of the fingers and toes, there will be opening up of the deep arteriovenous fistulas that will lead to bulbous enlargement. So this anoxic condition is mainly seen in some respiratory diseases like interstitial lung disease. So this theory will apply to this condition. Then comes humoral theory. So here many growth products like growth hormone, platelet derived growth factor, and other things are responsible, and some other hormones also like bradykinin, prostaglandins, all those things which might be released as a part of paraneoplastic manifestation commonly associated with bronchogenic carcinoma. So this is those things will lead to proliferation of the connective tissue or soft tissue causing clubbing. That is humoral theory. Then one more is recent one, newly accepted, is about PDGF. So in some inflammatory conditions, for example, inflammatory bowel disease and some other conditions in which there will be release of cytokines. So these will lead to excessive permeability of the capillaries at the nails. So excessive permeability of the capillaries will cause leakage of megakaryocytes, and those megakaryocytes and even the bunches of platelets will be stuck there. So they will release PDGF. They will release platelet derived growth factor, which will lead to proliferation of the soft tissue there. So this is considered as one of the most accepted theory again. Then comes neurogenic or reflex theory. They will say vagal stimulation because of any mechanism will lead to formation of the clubbing, which was proved whenever there is vagal neurectomy or vagotomy done for bronchogenic carcinoma. It has led to the reversal of clubbing. That's why they will consider this one also. So these are some theories which you have to know, correlating each with the conditions listed here. So this is about the definition, how to look for, what are the various gradings, and what are the conditions, and what are the theories postulated for development of clubbing. Coming to some higher level discussion related to clubbing are, they might ask what are the conditions for acute clubbing. So mainly we have listed out just now lung abscess, empyema thoracis, empyema. So in these situations there will be development of clubbing over just 10 to 14 days, and these are the conditions we can consider for causes of reversible clubbing. Then comes what are the conditions which will cause painful clubbing. So here we can list out subacute bacterial endocarditis causing clubbing will be painful. Then clubbing because of bronchogenic carcinoma might be painful. Then unilateral clubbing. So mainly any obstruction to the blood flow to the distal part on one side. For example, cervical rib, coarctation of aorta, upper lobe malignancy of lung, aneurysm of subclavian artery, or some AV fistulas of the vessels in the arm, that is brachial vessels. Again will lead to increased permeability, leading to the proliferation of hormonal products. So these are some MD level or postgraduate level discussions related to clubbing.